Can you refuse to take statins against your doctor's recommendation and still expect them to treat you? Well, let's look into that. Stay tuned. When I was looking into this question, I was getting kind of confused until I realized that there are a bunch of different contexts in which a refusal of care scenario can arise. So let's just quickly review those. First, there's the palliative or end-of-life care, where a patient may say, for example, I'm giving up chemotherapy. It's just too much to bear. It's not doing me any good. I just want to be made comfortable for the remaining days that I have. There's the emergency context in which you may refuse a blood transfusion, for example, for religious reasons. There's a psychiatric context in which you may not wish to be given certain mood-changing drugs. And then there is the maintenance or preventive context. And that's really the context that we're talking about when we're talking about statins. It's when you're sitting in front of your doctor and they're trying to put you on primary prevention or something of that sort. There are many different attitudes we may come across when we decide to refuse any treatment, so let's take a look at a few of those. First, there's this one from Duke Health, article entitled When Patients Refuse Treatment, and in it they say, patients may refuse treatment for many reasons, including financial concerns, fear, misinformation, they've always got to put that in there, and personal values and beliefs. Exploring these reasons with the patient may review a solution or a different approach. Well, if they're really looking for a different approach, in other words, a different treatment in our example other than statins, then this is really great. But a couple of things they don't mention here, and this wasn't necessarily meant to be an exhaustive list. Well, what about insufficient benefit? I mean, I could shoehorn that into personal values and beliefs. If we simply believe that we're not getting much benefit from this medication, then we may refuse to take it. And then there's what about past experience with medication under question. So that's the reason why I got off of statins. I was just having too many adverse effects, and kind of in a post hoc analysis, I discovered that there was really insufficient benefit there. On the whole, this article was actually fairly well balanced, and it was just giving advice to doctors on how to deal with this issue. So let's look at another one, and that is from a website called Nursing Central, article entitled Nursing Intervention for Medication Refuse. And in it they have this to say, it is important to remember that although it is in the patient's best interest to take the medications prescribed to them, they still have the right to refuse. Look at the way that this is framed. It is in the best interest of the patient to take the medications. There's no conditional there. It's usually in the best interest. It's just, it is in the best interest. And what this does is it plants a seed. Now, nurses are great people and they do a fantastic job, but it does plant that seed into them that the patient is refusing medications and they have the right to do so, but they're wrong to do so. We do have to acknowledge the context here. This was in the context of hospitalized patients, and maybe in that context, it is more common that it's always in the patient's best interest to take the medications, for example, post-op antibiotics or something like that. And let's compare that to Texas Medical Liability Trust. Article informed refusal when patients decline treatments. Now, I'm not going to go over all of them. This is actually giving advice to doctors of how to properly document that. But let's just look at the bottom two here. Clearly document that the patient has unequivocally and without condition refused the intervention. That's going to be important as we go on. And then identify why the patient refused, particularly if the patient's decision was rational and one that could not be overcome. What is that? That's an acknowledgement that it can be perfectly rational to refuse a particular treatment. So this doesn't have that hubristic attitude that it's in their best interest to take the medication that we've prescribed to them. This is, oh, there's a reason why a patient may refuse if it violates standards of care or something like that, I suppose. Then they just need to document it. So I think this is a much better attitude. These are all great articles though, quick reads, so you might want to follow the links to get to them. So let's quickly look at some legal and ethical issues. Every jurisdiction, and by jurisdiction I mean every country, every political division within countries, maybe locality, maybe even medical associations has different rules and different laws concerning refusal of care. So this is from a book entitled Refusal of Care. A patient's right to the refusal of care is founded upon one of the basic ethical principles of medicine, that is autonomy. This principle states that every person has a right to make informed decisions about their health care and that healthcare professionals should not impose their own beliefs or decisions upon their patients. That's a pretty straightforward statement, and it really respects the patient's rights. But what does this mean for continued treatment if you decline statins? I found another website that gives legal advice to doctors who may be faced with this called medicaljustice.com. When can you refuse to treat a patient? It had this to say. Patient noncompliance that impedes a doctor's ability to render proper care is a valid basis to refuse to treat. The underlying issue is that doctors are required to adhere to standard of care and so may refuse involvement in care that falls below that due to patient actions, the patient action being a refusal to take a medication. So in the case of statins, this would be the standard of care that says, for example, if you have a 92.5% chance of not having a heart attack in the next 10 years, then you qualify for statins. They put it the other way around. They say 7.5% risk of a heart attack or cardiovascular event in general in the next 10 years, then you're eligible for statins. Well, this is the medical profession, maybe not individuals within the medical profession, but this is the medical system, I'll put it that way. Talking on both sides of the mouth, you have the right to refuse, but we have the right to refuse to treat you if you exercise your right. So yeah, you have that right, don't exercise it, we'll drop you as a patient, or we can drop you as a patient. I find this very disturbing. So that leads me into a discussion about incompetence and incapacity, because there is a distinction there. Incompetence is a legal determination, requires a judge's order, a hearing, evidence to be presented, and if you're judged to be incompetent, some aspect of your life may be turned over to a guardian. You may be considered incompetent to make financial decisions, for example, or you may be considered incompetent to make your own medical decisions. Very serious matter, really not getting into that here. I really want to talk about incapacity, and that's a medical judgment. It doesn't require court or anything. It just is the doctors making a decision. Comes up a lot of times, obviously, in emergency rooms. If you're intoxicated, you're considered at least temporarily incapacitated as far as making medical decisions. If you're unconscious, well, obviously you can't express any medical wishes if you're unconscious. If you're a minor, you basically don't have the right to make these medical decisions, but your guardian, whoever it is, has to be sober and awake in order to make them for you. And then there are some psychiatric, mental health, or cognitive situations where you can be considered incapacitated. Perfect example of that is what happened to me a few months ago when I had an episode of transient global amnesia, and for a 6 to 8 hour period, I couldn't form short-term memories. I was basically cognitively impaired, and my wife had to make those decisions for me. And if she was not in the room, then the emergency room personnel had to do their best to make the best decisions for me. And they're legally protected in that case, and they really ought to be. The problem here is there is a loophole that you could drive an ambulance through, and that is a lack of understanding. So let's look into that a little further. There is a definition of capacity that I found in that same book that I quoted earlier, and it has 4 elements. First is the element of understanding, which says you need to be able to express understanding about your medical situation and your decision and the risks and benefits associated with that. There's consistency. The patient must express a clear, consistent choice without frequently changing their mind. Now, when you're sitting at a doctor's office, because that's the context we're talking about, and you're discussing statins, if the doctor is a longtime statin pusher, you don't really stand much of a chance raising objections with them. The same way that the average consumer goes and buys a car maybe every 5 to 7 years, and you're going to be dealing with a car salesman who sells several cars a week. They are experts at overcoming any objections you have. Well, the same thing with the statin-loving doctors. Appreciation is when you're able to apply the understanding of your medical situation to your own life. Perfect example of a lack of appreciation, also from that book, was if you know what a heart attack is and you can describe the symptoms and you can describe how it happens, a piece of plaque breaking off and lodging in your arteries to your heart, but despite being shown the evidence that the reason you're in the emergency room in heart pain is not because you have acid indigestion, but you're actually having a heart attack, and you refuse to believe it, well, you lack appreciation for your medical condition. And then finally, there is reasoning. It's your ability to infer the consequences of your decision and express why you would rather refuse care. And the reason I bring this up is because if you can go through these 4 areas and meet the criteria of capacity, your doctor's going to have a little bit of a harder time, I would think, justifying dropping you as a patient if that's indeed what they want to do. So let's look at how that might work. When you're sitting at your doctor's office having this discussion, let's look at those 4 areas and some sample questions from that book that I've already cited. The questions in the book were actually given more generically. I have actually edited them slightly in order to show how they may apply to the statin prescribing condition. First, there's understanding. You may be asked by your doctor, what do you think is the risk of adverse consequences from hypercholesterolemia? Easiest way to answer this is just go straight to the 2018 Pooled Cohort Equation risk calculator. And the risk calculators often give you, well, you could get it down to this if everything was perfect. And you say, well, I'm carrying an extra 2% risk because I have high cholesterol. Statistically, we can argue the truth or falsity of that, but let's just stick with the rules of the medical profession, because if you go outside those bounds, they're going to be all over you. So let's just play their game and show them that you have good reasons for not wanting to take the statin. Under consistency, they may ask after discussing the options, which option sounds best to you. I hope that the options they've discussed with you, besides statins, are lifestyle changes if you indeed do have a cholesterol problem. In my mind, high cholesterol in and of itself is just a marker. Unless they can show you you actually have plaque, keep that in mind, that it's just a marker. Under appreciation, they may ask, do you think you have hypercholesterolemia? Well, if that's the diagnosis, why argue against it? Hypercholesterolemia borderline is 200 milligrams per deciliter to 240 milligrams per deciliter. That's about 5.1 millimoles per liter to maybe 6.1, 6.2 millimoles per liter, something like that. And just say, yeah, by the diagnosis, I have that. And then they may ask, do you think statin treatment would benefit your condition and how? Well, you can go into the statistics of it. It might knock down the risk a little bit according to the studies that we've seen. And again, I'm just saying, go with it because it's easier to say, I accept your numbers and they aren't any good than to argue against the numbers. So let's just say that, okay, you get a 36% relative risk reduction from taking a statin. Well, if your risk is only 8%, well, 36% of 8% is only like less than 3%. You're not getting much of a reduction. And then they may ask, do you think statin treatment carries risk? Well, in my case, that's very easy to answer because I know it carries risk for me. I happen to get a lot of adverse effects from it. Now, a lot of people actually don't. And if you don't get adverse effects from it, well, maybe you can't argue this. Or if you've never taken statins, arguing about the adverse effects is going to carry a little bit less weight simply because they're only hypothetical at that point. But it's still good to bring them up. And then finally, reasoning. Well, why would you prefer to not take statins? For those of us who have experienced adverse effects, that's an easy one. I've had adverse effects. I was a danger to myself and people around me because of the cognitive impairments. How is high cholesterol going to affect your daily life? This is an important point. High cholesterol doesn't really impact your daily life for the most part. There are exceptions. If you have xanthoma or something like that, some condition in which a high cholesterol actually manifests itself in some other condition, yeah, it can affect your daily life. But for most of us, we wouldn't even know we had high cholesterol if we didn't get a blood test for it. So asking us how it affects our daily life, I'm going to say it really doesn't affect my daily life. It doesn't stop me from performing the normal functions of daily life. And then they'll ask, well, what is going to happen if you don't take statin? I've been tracking my lipid panel for quite a while and the risk associated with it according to the risk calculators, and it ranges between a 10-year risk of cardiovascular event between 5% and 8%. So over, say, the next 30 years, that turns out to be about somewhere between 14% and 23%. And I look at that and I say, well, if I don't take statins, I'm carrying a little bit of extra risk, but if I do take statins, in theory, according to your own numbers, doctor, it's going to reduce my risk by about 4 to 8% maybe. The trade-off between that and the well-known degradation in my quality of life, it's enough for me to say I still refuse to take the statins. So what are my conclusions from all of this? Well, in every jurisdiction that I could find information on, you have the absolute right to decline statins. It's unlikely that anybody's going to be trying to force statins down your throat, though the doctor may be trying to browbeat you into taking them. It is unethical for a doctor to drop you as a patient for declining statins. Yes, that's my opinion. I think it's a pretty solid one. Unfortunately, it may be legal, and that's where all these issues come into play. You need to prepare for your statin discussion with your doctor very carefully, because again, you may be sitting in front of a doctor who prescribes patients statins every day and is well versed in the psychological tricks that they need to take to get you to comply with their wishes. So therefore, you shouldn't feel pressured into answering probing questions without enough time to give them due considerations. In other words, the first time your doctor suggests you take statins, just say, okay, thanks for the suggestion, doctor. I would like to go away and study this. Give me a list of questions of things that I should consider, and I'll take a look at them, and I'll come back to you with a decision. And remember, you have the right to modify this decision in the future. So you may say, doc, for now, I don't want to take these. I want to try lifestyle changes. I want to look into it further. I want to get a CIMT, which is a carotid intimum media thickness test. That will actually show you if you have plaque and if you have a danger there. So you have the right to modify whatever decision you make. Now, when I was first browbeaten into taking statins, I was told, now you gotta promise you're gonna be on these for the rest of your life. I could feel my heart sink when they first said that. You can, like me, take the statins to begin with because you were browbeaten into it, but decide to get off them later, or you could decide, I'm not gonna get on them right now. We'll revisit it. Finally, you will need to do due diligence for your jurisdiction to determine your rights if your doctor threatens to drop you as a patient. Now, this is one of those things. If you've got a doctor who threatens to drop you because you won't take statins, well, maybe it's just as well that that doctor drops you and you get a different doctor who's a little more understanding and has a little more knowledge in this area. There are certain legal obligations that they may have in most jurisdictions if you're in the middle of some care that has, say, nothing to do with cardiovascular risk. For example, if you're on a course of antibiotics for Lyme disease or something like that, well, they have to continue that care until that treatment at least is completed. In many jurisdictions, they're obligated to find an alternative practitioner who will take over your care if they're going to refuse to continue to treat you. So I know this is a complicated area. There are no answers that are right in every jurisdiction. I hope this was helpful to you, and if you appreciate this content, please like, share, subscribe, and comment on this topic or others you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.